All right, we are going to get started. So my name is Linnea Zimmerman, and I am an associate professor in the Department of Population, Family, and Reproductive Health here at the Johns Hopkins Bloomberg School of Public Health. And I'm also the co-PI of PMA Ethiopia. So today we are here to really discuss the successes of the PMA Ethiopia project. The project, you'll learn more about it in a few moments, but we're winding down and we really wanted to have an opportunity to really showcase some of the successes, the learnings of the project. And so this is our opportunity to do so, as well as make people aware of the data and what can be done with it for your own research, program policy, and advocacy work. So that we will make sure that we're highlighting some relevant links and make sure people are aware of how they can access the data and use it for their own work. So this is just the goals of what we hope to cover for today. So we're going to learn about just a few of the innovative indicators and research that has been done with PMA Ethiopia through the platform itself, as well as some of the work that's been done towards actually having this data be used in policy and program implementation, as well as highlight how you can access the data for your own work. We will highlight just a few of the global collaborations that PMA Ethiopia has undertaken in the past 5 years, some of the regional, national, and global activities that we've done. We will also have a brief discussion of the capacity strengthening work that we've done to really transfer the technical and managerial work from the Hopkins-based team to solely the Addis Ababa-based team. And then finally, we'll end with the next steps for PMA Ethiopia, which is a sneak peek into the ePMA grant. So for those of you who are new to PMA Ethiopia, who are just joining us for the first time, I will give a very brief overview of the project. It was originally a 5-year project. It has become a 6-year project, implemented in collaboration with Addis Ababa University, Johns Hopkins University, and the Ethiopian Federal Ministry of Health. And it really had 3 primary outcomes. We're actually going to go in reverse order through these outcomes in this webinar and really end with the highlight of investment outcome 1. But the first outcome was to ensure country ownership and leadership to institutionalize the data within the country's data architecture. The second outcome was to really build the capacity of the Addis Ababa team and regional universities to take over the project by the end. And then the third was to expand the topical and geographic scope of the previous PMA 2020 platform and generate new learnings and information. In brief, the PMA Ethiopia platform is really a series of 3 different data collection activities, and they all fall under these broader goals of capacity transfer, testing new measures and generating new evidence, and promoting research and evidence in decision making. So those are our overarching objectives. And we had 3 data collection platforms that we used. So I will not go in detail, but I will link in a moment to the survey protocol that can be accessed to get more detail. The first data collection activity is a cross-sectional survey of women aged 15 to 49. This was done in every region in Ethiopia and is nationally representative, with the exception of Tigray for the years of 2020 and 2021. So the data were collected in 2019, 2020, 2021, and 2023. The second data collection activity is a service delivery point survey or health facility survey. This was also conducted nationally in the years listed here, as well as in cohort communities in 2022. And then finally, in that referenced cohort, what was really unique about PMA Ethiopia was that we followed 2 cohorts of women. So we enrolled women when they were currently pregnant, and then we followed them at 6 weeks, 6 months, and 1 year postpartum. And we did this twice. So we had the first cohort from 2019 to 2021, and the second cohort from 2021 to 2023. And we are going to highlight some of the research and data that were generated from each of these different survey collection activities so that you get a sense of what is available. Next slide. And this is in brief what we measured. So as I mentioned, one of the overarching objectives was really to gain new evidence and information. So we collected data across a wide range of reproductive, maternal, and newborn health indicators. This is a short list. There's much more that we have gathered, and I look forward to having our next speaker introduce some of that to you. So next slide. So we're going to move into the research and findings. Next slide. And our first speaker is Dr. Solomon Shifarov. He is an associate professor at the Addis Ababa University, and he is also the co-PI of both PMA Ethiopia and the new version of the grant ePMA, which we will learn about later. So I will turn it over to you, Solomon.
Thank you, Linnea, for the introduction. So my name is Solomon. I'm based at the School of Public Health at Addis Ababa University. We have been working with Linnea and the whole team of JHU colleagues since 2013. So in the next couple of minutes, I'll talk about some example highlights from the cross-sectional study as well as the panel studies that Linnea just mentioned. I would like to note that this is just only a highlight. So if you're interested to look at more publications, you can go to the website. So just to mention a few of most important findings. First is the revitalization of family planning counseling, which helped to shift the negative trajectory of quality of family planning counseling, which prevailed between 2015 and 2019. I will show you the graph for this soon. And another example is a consistent increase in long-acting method use over the last decade. So that is another example. The third is, of course, a relationship between a new measure that we tested about intention to use and empowerment with contraceptive use. So as you can see in these graphics, this shows the national as well as regional trends since 2014. As you can see, until 2015, particularly between 2015 and 2019, there was a decline, consistent, statistically significant decline in quality of family planning counseling. This was measured through 3 questions, as you might be aware. So if we asked women if they were counseled on other methods, and if they were counseled on side effects, and if they were counseled on side effects, how to address those side effects. So it's based on these 3 questions that we categorize women, the quality of counseling that women got. So it's considered as good if they say yes to all of these 3 questions. So following series of interventions, so the ministry acknowledged that this was a real decline, and they started to institute new initiatives, revitalizing a training program, developing pocket guides, and so on. So following that, initially we observed a positive change in Addis, and then it was reflected in all other regions, which was reflected also in the national figure. So this was a very good example of like before after intervention, if you like. So next. So this is another example of how we demonstrated the effect of measure testing, developing a new measure on empowerment. So we measure the relationship between empowerment and intention to use and actual use of MCPR. So as you can see, from the lowest to the highest, as MCPR, as in empowerment increases, both intention to use family planning as well as MCPR, actual modern contraceptive use, increased consistently. So it was the first time we demonstrated this, at least in our context. This is another unique feature of PMA. because we follow pregnant women through pregnancy in 1 year postpartum, we are able to track if women who have attended the first ANC also got, the final immunization dose for measles at 1 year postpartum. So as you can imagine, the percentage of women who got 4 or more ANC visits are significant. I mean, it's around 45%. Of course, it is still suboptimal, but it's relatively higher. But if you consider the proportion of women who got ANC 4 plus in delivery in health facilities, that comes down to 35%. Just a quick reminder, facility delivery in Ethiopia is around 62% around this time. So it's a combination of these two services, ANC 4 plus skill facility delivery, that brings down this figure to 35%. So if you go further to PNC, postnatal care within 6 weeks, it drops to 29%. And the final, measles immunization or full immunization to 14%. So actually, this is the figure from second cohort. In the first cohort, it was around 17%. So it has decreased a little bit over the last 2 years.
Thank you, Solomon. So just to highlight, those are again some of the unique data that we have. We have much more about the content of services that were received, the specific components and quality of care. And so we encourage people to dive into the data. I'm now very much pleased to introduce Jesh Dozier, who was recently at the Johns Hopkins Bloomberg School of Public Health as a PhD student, but is now at the University of Michigan as a postdoctoral fellow. And she is going to give us a brief overview of her research, which focused on a really unique aspect of our data, particularly related to women's abilities to make choices for themselves about their care. So I will turn it over to Jess.
Great. Thanks, Linnea, and hello, everyone. Thanks for being here today. I want to just jump right in and talking about what is reproductive coercion. So reproductive coercion is a type of intimate partner violence that is increasingly recognized as a significant public health issue worldwide. Much of the current literature focuses on RC perpetrated against women by a male partner and defines RC as behaviors by a male partner that undermine women's autonomy to make decisions about her reproductive health. So this can look like exerting control over pregnancy and pregnancy outcomes. And typically, when we talk about RC, we think about pregnancy coercion or attempts by a partner to force a woman into becoming pregnant or control the outcome of a pregnancy. And birth control sabotage or interference with contraception. So one example of this might be preventing a woman from accessing a family planning clinic. From the larger PMA project, we know that RC is common in sub-Saharan Africa, with estimates ranging from 3 to 20% in population-based studies. And the broader literature suggests associations between RC and sexually transmitted infections, unintended pregnancy, and poor mental health. Currently, the reproductive coercion scale, developed by Elizabeth Miller and colleagues in the United States, is the most comprehensive tool for measuring RC. These 9 items, which measure pregnancy-promoting behavior by a partner, have recently been adapted and validated in sub-Saharan Africa with moderate internal consistency. What's really cool about PMA Ethiopia is that the project includes RC measures in multiple surveys, including the 2019, 2021, and 2023 cross-sections, the cohort 1 and 2 baseline surveys, and measures of postpartum RC in the cohort 2 1-year postpartum survey. In the 2019 cross-section and cohort 1 baseline, there were 5 yes/no questions included, where women were asked, in the past 12 months, has your husband or partner told you not to use family planning, hurt you physically because you did not agree to get pregnant, said he would leave you if you did not get pregnant, told you he would have a baby with someone else if you didn't get pregnant, or took away your family planning or kept you from going to the clinic to get family planning? Items were refined for the sub-Saharan African context in the 2021 and 2023 cross-section and in the cohort 2 baseline. Specifically, the item told you not to use family planning was split into 2 separate items where partner intent was more clearly outlined. And these include made you feel bad or treated you badly for wanting to use a family planning method and tried to force you to become pregnant. And finally, as I mentioned, there are measures of postpartum RC in cohort 2 at 1 year postpartum, including 6 items asking women about experiences of RC since the birth of their most recent child. Using these RC measures, we can get an idea of the prevalence of RC in Ethiopia. We estimate that 1 in 5 women of reproductive age have experienced RC in the past year. 1 in 3 women experience RC in the year before pregnancy, and 1 in 10 women experience RC in the period after giving birth. So clearly, this is a common issue that warrants further investigation. So PMA Ethiopia has contributed to the understanding of reproductive coercion, including documenting associations between RC and decreased odds of modern contraceptive use, RC and use of contraception that is hidden from a woman's partner. This is called covert use. RC and women delaying conversations with their partner about their current method use until after they have started using it. And finally, there's also some evidence that RC may be associated with child health outcomes, which require further exploration. So now for a brief overview of some of the ongoing work that's currently under review and using data from women who were pregnant during enrollment of cohort 2 and who had completed at least 1 follow-up interview, we sought to explore the relationship between RC and the initiation of modern contraception in the 12-month postpartum period. The exposure was past year RC measured at baseline, and our outcome was time to adoption of modern contraception, which we assessed using a 12-month reproductive calendar. We used time to event or survival analysis methods to answer our research questions. And I want to get into some of the results now. Next slide. So let's look at the failure curve first on the left. The blue line on the top represents women who did not report RC, and the red line on the bottom represents women who did report RC. We can see that overall, compared to women who did not experience RC, fewer women exposed to RC adopted contraception across the 12-month postpartum period. So for example, by 12 months postpartum, about 42% of women who experienced RC had adopted a method versus 50% of women who did not experience RC. Now, something interesting happens when we stratify by urban-rural residents. Looking at the curve on the right, adoption rates were significantly different when stratified by RC and residents. Rural women exposed to RC, which is represented by the bottom orange line, had significantly lower adoption rates than their counterparts who did not report RC. So this may suggest that RC may compound barriers that rural women face to using contraception, such as limited access to health services, and really points to a need for programs in rural areas to consider RC as a potential barrier to the timely uptake of postpartum contraception. We see that regardless of RC exposure, urban women adopted contraception faster than their rural counterparts, which is unsurprising to this audience. However, urban women exposed to RC, which is represented by the top red line, had the fastest adoption rates overall. One possible explanation is that urban women who recently experienced RC in the period before pregnancy may have a heightened sense of urgency and need to prevent unintended and closely spaced pregnancies once they're postpartum. They may be able to use contraception, more able to use contraception covertly or hidden from their partner, and therefore uptake postpartum contraception faster because they can more easily access and use methods without their partner's knowledge or interference. Next slide. So getting into the results from our survival models, the adjusted results without an interaction term show no association between RC and postpartum contraceptive adoption. That's the hazard ratio of 0.91. However, given that we hypothesized the relationship between RC and postpartum contraceptive use, might vary by urban-rural residents, we included an interaction term in the final model. This result suggests that the effect of RC on time to adoption varies by residents. The hazard ratio here of 0.6 for the interaction term suggests that RC is associated with a 40% decreased hazard of adoption of postpartum contraception among rural women. And again, this points to a need for programs in rural areas to address RC as a potential barrier to timely uptake of postpartum contraception. Next slide. So to wrap up, we know that the first year postpartum is an important time for preventing unintended and closely spaced pregnancies in order to reduce risk to mom and baby. However, RC undermines women's reproductive autonomy in contraceptive use, which may make it more difficult for women to achieve their desired pregnancy spacing. Now, I didn't cover it for the sake of time, but we also have ongoing work that found severe forms of RC increase the likelihood of women having another pregnancy within 12 months of giving birth. So early intervention is going to be essential here. And this work points to the need to recognize RC, the role of RC and partners in women's reproductive health. Family planning programs should incorporate RC screening and intervention into women-centered pregnancy and postpartum family counseling. And finally, it goes without saying that we must engage boys and men to shift harmful gender norms that enable RC. And in conclusion, you can see from the PMA Ethiopia that this data provides a unique opportunity to examine RC in a high fertility setting and inform efforts to improve reproductive health and bolster women's reproductive autonomy. And I'm happy to answer any questions in the chat. Thank you.
Thank you, Jess. I do see a number of questions in the chat. If you don't mind, if you can please put questions in the Q&A. And we just ask that you do that because it's a bit easier to keep track and make sure we aren't missing anything in the flurry of links and introductions, etc. So please do, if you put a question in the chat, just please put it in the Q&A. We will try and answer as we go along through the webinar, and then anything we aren't able to answer during the presentations, we will get to at the end, but we will try and answer everyone's question. So for this next section, it's back to me, and I am going to be talking a little bit about some of the health facility data and how it can be used, and how it can be used to build evidence. So next slide. All right, so as we mentioned before, the health facility or the SDP data was collected annually. Generally, it was collected nationally. There was 1 year where it was collected only in certain regions. But because of the frequency and the way that the data were collected, as well as how we selected health facilities, it's possible to use the SDP data in 3 ways. So I'm going to go back just a little bit to discuss how we selected the health facilities. I mentioned in the beginning that we conducted a cross-sectional, nationally representative sample survey. So when we identified the enumeration areas or the communities in which we were going to be doing the survey, we also identified the health post, health center, and hospitals that served those communities. And those were the health facilities that made up our SDP sample. So every time that we conducted our cross-sectional, nationally representative survey of women, we also went back to those health facilities. We selected both public and private health facilities. Public facilities were surveyed every year as long as they were accessible. Private facilities could vary a little bit, as we would do random selection of private facilities if there were more than 3 in the area. So I'm just giving that background so that it's clear how you can use this data. So again, there are 3 ways that you can use it. The first is sort of just a cross-sectional use of the data. You can use it just as in we collected the data in 2023, you can use the data from 2023. And that's an example that I'll show in a minute in terms of HMIS validation. A second way that you can use the data is to actually link between the facility data and the individual data. So we have information in both the individual data set and the health facility data set on the enumeration areas. And so you can actually link between, this facility that serves enumeration area 1 and then all the observations from enumeration area 1. And then finally, because we went back to the same set of SDPs every year, you can actually conduct a longitudinal analysis of the SDPs and using them as panel observations. So I'm going to just show a couple of examples of how that was done. So the next slide, please. Thank you. So this analysis was led by the Addis Ababa team. And in it, they were actually using the data. I believe this is from 2023, but the team can please correct me if I am mistaken. And so the data, each time that we went to a service delivery point, we looked at the record books, the log books, to identify the number of visits of certain sort of high profile or important indicators that we were particularly interested in. And so that included antenatal care, skilled birth attendance, vaccines, and family planning, as well as others. So in this analysis, the team looked at the number of visits that had been conducted and recorded in the logbook, and then cross-checked that against the HMIS data that we had for those same facilities. And they were able to see if what was recorded in the logbook was verified at the HMIS level. And you can see here that for skilled birth attendants and Penta 1 vaccines, the estimates were fairly comparable. What was in the logbooks more or less matched with what was in the HMIS. But for antenatal care and for family planning, there was actually significant overestimate of service by the HMIS. And so this is indicating sort of there's some substantial over-reporting for some of these key indicators that are used to track coverage within Ethiopia and in many other places. So this is just one example of sort of how the PMA Ethiopia data can be used when it's able to be linked back to the HMIS. The second piece that I mentioned was actually using the service delivery point data to make linkages between the individual data and the health facility data. So as I mentioned before, we selected the health facilities based on whether they serve the communities. And in this case, these are 3 papers where we actually were able to link the health facility data directly to the individuals and explore how specific characteristics of health facilities were associated with any specific individual outcomes. So the first that we looked at was looking at the readiness of facilities to offer maternal health care. The second looked at receipt of immediate postpartum family planning counseling. And the third looked at whether women's knowledge of abortion availability and legality depended on the service delivery environment in which she lived. And just highlighting this first one, so this was done by Elizabeth Stearman, who is now an assistant scientist in the Department of International Health at Johns Hopkins. And she used this data for her dissertation and identified that as health facilities had improving scores in readiness, so as they were sort of more ready to offer comprehensive maternal care, this was associated with an increased odds of a woman in that community delivering in a health facility. So sort of making this direct link to show that the higher quality, as measured by service readiness, there are many dimensions to quality, but one of them being service readiness. As service readiness improved, women had a greater likelihood of delivering in a facility. All right, and then our last demonstration of using the SDP data. So in this case, the data were actually linked over time. And so we were actually able to link each of the SDP observations across the 4 years. In this case, we did not use the 2023 data. It was not yet available, but we linked across 2019, 2020, 2021, and 2022, and created a panel of health facility data. And in this case, we were looking at whether or not there was significant change in maternal and newborn service readiness, contraceptive method availability, and PPE commodity availability. So next slide. This report, I will also put a link in the chat as we go along, so you can, if there's more information, there's a lot more analyses than these 2 slides that I'm going to present. But this first is just showing how maternal and newborn health service readiness changed over time. So one of the ways that this was done was was a score that was developed using a health service readiness score. And this was done on a number of domains. So it included medicine and commodities, equipment, supplies, and amenities, staffing and systems, and then signal functions. And this graph here is showing within a facility, whether there was significant change in that readiness score between 2019 to 2020, whether there was change between 2020 and 2021, and then finally, whether there was change between 2021 and 2022. So you can see that particularly in 2019 to 2021, there wasn't much change in the score. So most facilities were actually the highest number of facilities had very little change. But then there was this distribution where there were facilities that had actually a significant amount of change in their score. And then in 2021 and 2022, this changes a little bit more, and we can see that there's sort of a shift where there are a number of facilities that have higher scores, so they appear to be more ready. But then there's also a larger number that are also shifting in the opposite direction. And so what was happening between 2021 and 2022, we have to look more into the details about what some of that is, but it points to sort of perhaps that there were some commodities, medicine and commodity shortages or changes in the supply chain that were affecting facilities differently. And that's the kind of analysis that you can do with this data. Next slide. So we also looked at commodity availability for family planning. And in this case, what we found is that we used a benchmark to say the facility is ready, it has X number of commodities available versus these facilities don't meet that benchmark. And over time, you can see in the purple that health facilities tended, if they met the benchmark in 1 year, they tended to meet it again in the next year. So facilities that were ready to provide contraceptive services in 1 year tended to meet it. But if they failed to meet it, then it was much less likely that they would meet it again in the future. And so this suggests that, it may be more useful to specifically target those facilities who are failing to meet the benchmark and make sure that we're able to bring them up and address those sort of specific challenges that health facilities are facing, as opposed to these broad generic, perhaps means of improving commodity security, as some facilities are clearly able to meet their commodity security goals while others are falling behind. And again, these are just the kinds of analyses that can be done, and we will link to the specific report if you want to read more about that. So with that was a real very quick snapshot of just some of the results, some of the ways you can use the data. We're actually going to shift gears a little bit and talk more about how the data have actually been used to inform some of the goals of the national government, as well as monitor and evaluate some sort of global programs. So as I said, we're going to shift gears. Thank you. And we have a number of examples that we're going to show. Again, we're going to keep them very brief for the sake of time. But PMA Ethiopia data have informed both regional, national, and global efforts to improve reproductive maternal health. Dr. Solomon has already highlighted one reflected in the quality of care of the family planning. And Dr. Asafa Seme, who is the other co-PI of PMA Ethiopia, as well as an associate professor at Addis Ababa University, is going to talk to us in a moment about a few more examples of how the data have been used. But we will also highlight 2 other efforts where we used data to inform efforts at the global scale, including the Global Financing Facility and the HIPS effort at FP 2030. So next slide. And I'll turn it over to Dr. Asafa.
Thank you very much, Linnea. Yes, well, when EPMA's accomplishment, one of the accomplishment that PMA did was the official commissioning of the PMA Ethiopia platform, which was endorsed by Policy and Planning Directorate to respond to the data needs of the Ministry of Health in the broader areas of MNH and family planning. So our team, once this has been officially commissioned, we've established the project advisory board. We have drafted questionnaires, get consensus with all the stakeholders, and we collected, monitored data, and presented for decision making for the Ministry of Health and all stakeholders. One of the accomplishments we did since 2019. The other accomplishment is the fact using the PMA platform is that the FPC, the Family Planning by Choice project, which was actually funded by FCDO, or it's around 19 million Great Britain pound project. This has been, again, has used PMA for monitoring its key performance indicator. It was a sort of performance-based financing. Certain indicators have been selected, agreed upon by the FCDO and the Federal Ministry of Health. The Federal Ministry of Health has to fulfill the agreed upon indicators to get that funding. So PMA has contributed by providing independent indicators either for funding or not provide the funding. That is one of the other accomplishment. The PMA platform has also been used by UNFPA Ethiopia, who has supported the Reproductive Health Commodity Security Survey, which is an annual facility-based survey using the PMA Ethiopia platform since 2014. The finding from this survey has been used by the Federal Ministry of Health and other partners for planning and resource mobilization. So this is another contribution of the PMA platform. Last but not least, we have also worked a number of studies with Guttmacher Institute using the PMA platform. One was a follow-up study which we measured to measure the impact of global gag rule on the family planning and safe abortion service using a PMA platform for data collection and further analysis and dissemination. Of course, we have actually published an article in the Studies in Family Planning journal entitled as Trump Administration's Expanded Global Gag Rule Policy on Family Planning Service Provision in Ethiopia. This was done in the first term of Trump's administration. I think the same thing is now being repeated. I'm sure the article worth reading because there are a lot of recommendations that has been provided in that articles. One of the recommendations we provided was that all actors, including the Federal Ministry of Health, regional health bureaus, and non-governmental organizations working on family planning and reproductive health, generally have been advised to look for alternative source of funding, particularly turning their face to domestic resource mobilization, and relying on external aid could be dangerous and could affect the health of their people. Thank you very much.
Thank you, Safa. I am going to also briefly present on these two initiatives that we have undertaken to help inform monitoring and evaluation. The first is of family planning. For those who are not aware of the high impact practices, or the HIPs, they are a set of evidence-based practices that have been shown to, when implemented correctly, ideally can lead to increased contraceptive use. There are a number of HIPs. I'm not listed them all out here, but the PMA Ethiopia data were used to, we looked at what is collected in PMA Ethiopia data, and looked at which of the HIPs we could inform with our data. And so this is, again, just one snapshot. But for example, one of the HIPs is improving knowledge through the use of mass communication, and we looked at what percentage of women were accessing family planning across different forms of media, including TV, radio, newspapers, and social media. And then we also looked at how these varied by region. So this is, again, just one small screenshot from the HIPS brief, and I will post that in the chat as well. But we were able to just demonstrate how the implementation of the HIPS sort of on the broad scale, what that looked like, where there might be some gaps, as well as identifying how those might vary by region. And so, of course, here we can see that women in Addis Ababa were much more likely to be accessing information or hearing about contraceptive information on both the radio and the TV than women in other settings. And that disparity is particularly clear for the TV. But we show this across different kinds of different kinds of sociodemographic characteristics, including age and education and region. And so it's a helpful way to see where there might be, again, areas to intervene or target if you are implementing a program that's informed by the HIPS. Next slide. So this is our last example. Oh, I'm sorry, there's two more, this one and one more. So this is an example where we worked with the MAGE project, which is housed again at the Johns Hopkins School of Public Health, Bloomberg School of Public Health. But the MAGE project is informing the Global Financing Facility and their efforts to improve reproductive and maternal and newborn care globally. So using some of the data from Ethiopia, where we collected data using a scale called the PCMC scale, person-centered maternity care, and we identified some of those items as well as other items that we felt were relevant to meeting women's basic needs, preferences, and support for informed decision-making during delivery. And we looked at these different indicators across as a scale. Here you can see that we have put together some items as whether or not facilities or whether or not women reported that their basic needs were met. And so that included things like, was their health checked on after delivery? Were they covered or screened during delivery? Did anyone talk to them about how they were feeling? So this is sort of the basic, like where their basic needs met. And then we identified indicators that we felt were more representative of whether their preferences were met. So were they allowed to have someone with them? Were they able to be in the position of their choice? And were they allowed to ask any questions during delivery? And then finally, we looked at whether women were actually allowed to participate in the decision-making process. And so was there information that was exchanged about medicines or procedures explained to them? Did healthcare workers obtain consent, et cetera? And so you can see that in general, women's basic care is much more likely to be met than whether or not they were able to actually participate in the decision-making process. And so these results, as well as many others, and again, we'll link to that as well, have been shared with the Global Financing Facility, as well as the Federal Ministry of Health, and are being used to ideally guide ways to improve the maternal health and specifically skilled delivery at birth practices in Ethiopia. All right, last slide. This one, I just want to highlight for those of you who are interested in using the data. So the International Conference on Family Planning, as many of you, I hope, know, the abstract submission portal is currently open. Abstracts are due March 15th. All of the data that we are referencing here, whether it be from the cross-sectional national surveys, the health facility data, or the cohort data, all of that data are publicly available at this link here, and people can access it for free. You can use it for whatever purpose you like, but just promoting that if you are particularly interested in contraception or reproductive health more broadly, that this is as an opportunity to use that data and hopefully be able to share your results. And just noting as well that the Ethiopia data have already contributed to 85 publications to date, 25 of which were led by Ethiopian-based researchers, and then 7 specifically by the PMA Ethiopia team. And so highlighting, again, the broad range and focus of PMA and its ability to contribute to the evidence base. So with that, we are going to shift gears a little bit away from some of our data and how it's been used and talk a little bit more about the specific capacity strengthening activities that we have done to really transfer the technical and managerial focus to the Addis Ababa team, and I'm very pleased to introduce Mahari Yadego. He's really the heart and soul of this project. I have to say, without Mahari, we would all be sunk. And so I can't say enough good things about him, but he is really our project coordinator and again, heart, soul, brain, gatekeeper, and everything else. So with that, Mahari, please continue.
Okay. Thank you very much, Linnea, for the introduction and for the generous words. Hello, everyone. I'm Mahari. I'm currently working as a PMA project coordinator, and I will be presenting you some of the capacity building activities that have been done. So among the 3 primary investment outcomes, the second one is capacity building of those local staffs, which is very critical even to realize the first outcome, which is ensuring country ownership. So we will be focusing on the second outcome. Next, please. So we have focused on individual and teams capacity building activities so that staffs at the AAU can take on fully the responsibilities of conducting different activities of the survey, like ODK programming, field staff training, survey tool development, data management, data analysis, and communications. So in order to conduct this capacity building activity, we have relied on a capacity building, a capacity need assessment that was conducted by an independent consultant with Dr. Yared Mokanen. And Dr. Yared conducted both the baseline assessment and endline assessment. Additionally, to develop the capacity of researchers based at the AAU and other regional universities, we have also conducted short course data analysis on advanced data analysis trainings. And also there have been a PhD mentorship program for students that are who were enrolled in various universities in Ethiopia. Next, please. So the baseline need assessment primarily identified the main capacity needs within the PMA Ethiopia survey continuum, and the additional management supports that were needed to conduct the PMA survey, both cross-sectional and panel survey. So that baseline assessment had helped us to outline, it also outlined the recommendations on the capacity needs, And the inline assessment, the findings of this report had informed the prioritization of capacity strengthening activities for the remainder of the grant. So as part of the capacity building activities, both to individuals and team capacity, we have used several tools like self-assessment tools, extensive tools to assess individual capacity needs. And we have also created individual and team-based resources and tools based on the result of those self-assessments. And we have also created and organized training, both virtual and in-person, for the staff involved in the survey. Their RACIDs were used to delineate tasks and roles, and boot camps will let participants to engage in boot camps, and some of our staffs have got funding also to participate in a professional development courses. So while doing this, we were basing mainly on the capacity need assessment findings that were done by Dr. Yared. So the end-line report. So we conducted the end-line report ahead of concluding the grant, which was in February 2023, so that it helped us to assess and to assess the current capacity, the capacity status of the AAU team, and identify outstanding capacity strengths, the bottlenecks, the weaknesses in various tasks. And it has also helped us to assess to what extent the recommendations made at the baseline capacity assessment have been implemented. Reports also assess that the GHU team's overall capacity strengthening activities to date. Okay, so opportunities and lessons learned from these capacity building activities. So Dr. Yared Mokonnen is a highly respected researcher in Ethiopia, and he has been neutral. He was a neutral observer and reviewer of our work. And the self-assessment, though self-assessments are strong tools, but the need assessment that was conducted by Dr. Yared includes very extensive in-depth interviews, material reviews, and so on. So it gave us to go beyond this self-assessment type of need assessment. So that was very supportive. So Dr. Yared's findings allow for more collaborative process, in developing our plan. So both the JHU and the AE team have been participating together in developing their work plans. So even in the end-line assessment, there were some capacity strengthening needs that were identified, but because of short of funding, we were not able to implement them. So overall, despite challenges over the course of the grant period, AAU has clearly demonstrated improved capacity across several technical and administrative dimensions. This was clearly demonstrated given AAU has successfully submitted a grant proposal, which was accepted. Thank you.
Yes, thank you very much, Mahari, and thank you very much, Dr. Yared. I know that you are here, and we appreciate all of the work that you did to help guide the capacity building efforts. So we've had a number of questions in the chat about what is next. How can people collaborate? What is the plan for sustainability? And so I'm very pleased to turn this over, I believe, again to Dr. Asefa, who is going to talk about the next stage of PMA Ethiopia, which is now fully owned, managed, operated, and run by the Addis Ababa team. So Dr. Asefa, please take it away again.
Thank you very much, Dr. Linia, again. The journey is not stopped. We are still in the move. We have had all the primary investment outcomes that we have implemented through. Now, what is the next? So, the next slide, please. So, as has been mentioned, we have had capacities that was built over the past few years, and so accordingly.
I think we may have lost Asefa. Solomon?
Yeah, I can I can step in. Linear. Until Asefa comes. Can you hear me, Linear?
Yes, we can. Thank you.
So the current grants, which is funded for 4 years, 4 years from 2024 to 2029, has two investment outcomes. One is country-owned RMNSH survey research
Solomon,
platform.
did you take over?
Yeah, now
Okay.
you can.
Am I cut?
Yeah, you were.
Oh, sorry. Can you hear me now?
Yes, sure.
So, what is the next step? In the next step, sorry for the interruption. The Ethiopian team has already embarked on a 5-year new grant after submitting the proposal to the foundation. Bids from 2024 to 2029. It is called EPMA grant. The EPMA grant has two outcomes. One is ensuring country-owned RMNC survey research platform established within the country data structure. The second one is establish a center of excellence in RMNCH survey research in East Africa. Under the first primary outcome, we plan to conduct 2 national RMNC surveys, one by the end of 2025 and the other by the end of 2027, provided that funding is obtained for the latter. So we have already started preparations. We began for the upcoming survey, including, the revitalization of the project advisory board, which is led by His Excellency the State Minister of Health. This process involves, again, adding some new members, which are not part of the previous PAB, such as, representatives from EPHI and Ethiopian Statistical Service, while also replacing individuals who organization from thorough audit and the screening of survey questionnaires used in the past to assess their timeliness, relevance, and overall usefulness. Furthermore, we are also engaging key partners in identifying and prioritizing critical issues, critical focus areas for the survey that aligns with the current national health priorities and the data needs. Under the second outcome, what we are doing, there are ongoing activities like developing short courses, capacity building of local staff, and also, sort of gender balanced postdoc training. We have already prepared the guideline and have aired some announcement to recruit postdoc trainees. I think if applicants would like to apply, I think the deadline is coming soon, so you can look into the PMA website. So currently, together with the London School of Hygiene and Tropical Medicine, which is collaborating with us on capacity building, we are conducting need assessment for this, establishing a center on RMNCS survey, analytics, and translation, which we call RSAT for short. This proposed center is to be established within the School of Public Health of Addis Ababa University. The aim is to serve as a hub for building the capacity of both local and international professionals in the areas of survey design, data analytics, and evidence translation, with particular focus on RMNCH. To ensure, again, its long-term sustainability, the center will be designed as semi-autonomous institution capable of attracting external funding while also developing mechanisms to generate its own resources. So this strategic approach will enable the center to maintain financial independence, expand its research and training initiatives, and continuously contribute to strengthening data-driven decision-making in RMNCH, both nationally and internationally. The second ongoing activity is development of short courses that could potentially be integrated into the regular graduate programs and also attract some international course participants. This capacity building process is being implemented, as I told you earlier, in collaboration with London School of Hygiene and Tropical Medicine. This is a renowned institution with extensive expertise in public health research, survey methodology, and data analytics. I think we can make use of their expertise.
I think we may have lost Dr. Asafa again. Solomon, can you just again step in briefly? Thank you.
Sure. I think has almost concluded. So the last piece was another new initiative that we have started working with the Clinton Health Access Initiative to monitor progress towards the goals of the Family Planning Compact Initiative. It's a multi-donor 3-year grant, including the Gates Foundation, which is aimed at increasing domestic resource mobilization for family planning and essential maternal health commodities. So actually we are preparing to do the first survey, and it will be combined with the UNFPA reproductive health commodity security survey. So fortunately, we managed to create synergies between these two surveys. So it will have one survey instead of two surveys. So we'll have another follow-up in 2026. So the 2024 was a desk review. 2025 we'll do a survey shortly, probably around April this year. So that is the updates that we have regarding ongoing activities. Maybe next.
We do have time. We have about 10 minutes left if people are able to stay on for questions. We have been trying to answer questions in the Q&A as we go along. But if there are any specific questions, I think we're able to unmute. So people, if you do have any specific questions you'd like to ask, please feel free to raise your hand. And in the meantime, maybe I can just ask Solomon and Asefa, I think there were some questions just about the PhD fellowships and being engaged as PhD. So maybe you could speak just a little bit more about the fellowship that you mentioned.
Sure. So we have announced the postdoc vacancy on the AU Addis Ababa University website and the school. So this round, it is limited to Addis Ababa University staff. I mean, the opportunity is limited, not just the School of Public Health, but the broader Addis Ababa University. But we have other short courses, which is coming. So that will be available for all regional universities across the country, including the CBMP universities. This is a capacity building and mentorship program that's funded by the Gates Foundation. So the lead organization for that is University of Gondar, and London School of Hygiene. But we are also collaborating with them. So that opportunity will be available soon. So once that's available, we'll also post that opportunity.
Great. Another question. So are the data use workshops open to those who are willing to participate from other organizations, such as health-related NGOs?
Sure. So we have the key stakeholders from who are also member of the project advisory board. So we think many of the key stakeholders in the country are included. But if there are people who are interested from other related relevant stakeholders, I think we can entertain that, given it's within the number of attendees that we expect. Yeah.
Great. And our last question, sorry, Dr. Asefa, did you want to add anything there?
Yeah, I just wanted to emphasize on, one of the reason for this data utilization, organization of data utilization workshop is to make effective utilization of data for evidence-based decision. As you know, what we do nationally, the analysis may not go in detail or could not be region specific or area specific. So they are highly encouraged to come make and get trained and do their own analysis and sort of customize to their needs. That's what I would like to add. Yeah.
Thank you. We have a few more minutes, so I'm going back to the chat. I think there's one question left in the Q&A. Oh, there's another one. From your graph, trends in good counseling is very low in Amhara region relative to other regions, but the CPR is relatively high and the TFR is lower in Amhara compared to the other regions. Can you just comment on those patterns?
Oh yeah, I tried to respond that in the chat, in the Q&A, but the rest of the audience, if it is of interest. So since we started tracking MCPR and quality of family planning counseling in 2014, the pattern, the trend in Amhara was stagnation or a little bit of decline and so on. So it was not increasing. But the quality of counseling, of course, is true. It is very low. It's low nationally, but it is particularly low also in that region. So just to say that it was not increasing while family planning counseling was decreasing, we don't need to be confused with that. So it was already stagnating or decreasing since we have been tracking MCPR in the last 10 years. So any increase in MCPR in Amhara region was before 2014, at least. That's what we can say, or after 2015 to 2005, if you look at the DHS figures. Yeah, over to you.
Thank you. Let's see. I think I'm going to answer one quick question, which was related to Tigray. And just to clarify that while we did not collect data in Tigray in 2020 and 2021, it has now been added back into the survey. And so there's already the 2023 data include data from Tigray, and the new EPMA will also, I believe, correct? Yes, will also.
Sure. Yeah.
So there will be more information there. And then I'm going to end with just this last question. Why is the data collected by PMA Ethiopia important? And how do healthcare professionals, policymakers, and other stakeholders use it?
You want us to respond?
Yeah, why is it important? Why did we do this for 5 or 6 years?
Yeah, maybe to give the main background, the reason why PMA was supported in the first place was Ethiopia committed to, with other countries, of course, in the London summit in 2012, to have its own share of contribution to the global goals of reaching 120 million new contraceptive users. So I think around 6 million contraceptive users, new contraceptive users was a goal from Ethiopian side. So we had to monitor in order to see if we're moving in the right direction. So that was the main reason. So we have been providing that data since 2014. But of course, over time, we have expanded in terms of topical areas to cover the broader MAGE, continuum of care, quality of care, and other dimensions. And that has helped, of course, also the sample size in regions throughout the country. So we are now able to provide national as well as region specific estimates for the key MCPR family planning indicators. So over time, our value has increased beyond family planning. So the ministry, if you look at many of the documents, the ministry's strategic documents in the last couple of years, they were informed by PMA in one or another way. So it has been critical to the ministry's initiatives and monitoring and evaluation efforts. Yeah, over to you. Maybe you can add something.
I think, yeah. Go ahead, please.
Yeah. Today, even though, the very first reason was mentioned by Solomon, the purpose for PMS, establishment today, I could say the primary source of data for the ministry and its partners is PMA. In the absence of, not only in the absence of other big surveys like DHS, but also as, validation for their routine data sources. So PMA is so important. It informs policies, it informs decision making and so on, not only for the ministry, but also for all the partners working in health area. Yeah.
Thank you very much. We are at time. If people do have any additional questions, the communications officer and has kindly posted to the X handle, and so people can please add any additional questions there. We very much appreciate all of you taking your time to join us today. And it's really been a pleasure over the past several years to co-lead this project with such an incredible team. And there's one person who we didn't get to feature, but I would just like to really give a heartfelt thanks to Salam Desta, who was our associate director over these past many years and has been, along with Mahari, the heart and soul of this team. And so many, many thanks to all of the people who joined us and contributed to the success of this program. So thank you all very much.
Thank you.
Thank you. Maybe just to say hi to everyone.
Yeah, thank you, everyone.
Yeah. Thank you.